at the University of Michigan, and I'm very glad you're all here. And so far, there are about 41, now 42. We have a poll among the staff as to how many people we'll have at this, and I know a few of them have already lost, but we'll see how it unfolds when everybody's here. I want to acknowledge Kathy Kurgianis, who did all of the arrangements for the workshop. Kathy, when you keep count of the number of people who were here when I started, don't cheat, okay, please. All right, so let me share my slides and we will get started. Can you all see?
Looks great.
I need an affirmative from somebody.
Looks good.
Okay, so here is the plan for today. We'll begin with just a general introduction and overview of the schedule, and I have to apologize in advance for my intermittent coughing here. And I think everything in Southeast Michigan bloomed all at once in the past few days, so we're all kind of pollinated here. So that's the piece of the workshop that we are engaged in right now. At about 1:10, we will move into an introductory lecture that I hope will be punctuated with some discussion. I will stop at a few points and invite comments and questions. And then at 2:20, when that part of the workshop ends, we will begin our work on a simulation exercise, which I hope will give you an opportunity to put into some deeper level of understanding and appreciation the ideas around learning health systems that were introduced in the introductory lecture. We'll then divide you randomly into groups of about 7, and Kathy will do the Zoom work to do that, and you will work in groups on the simulation exercise that was emailed to you, and you're going to need that, and you're going to need the answer sheet that was also emailed to you. If you do not have those documents, put your email address in the chat, and Kathy will send those documents to you. So please do that if you don't have these documents that were sent in email. Then we'll spend about half an hour getting the group's reports back to share the work they did, and we'll have an interesting exercise of comparison and contrast, and then we will wrap up for the last 15 minutes. So that is the general plan. The goal of this activity is to give you a deeper sense than you may have already had of what this idea of a learning system is, and then through the simulation exercise to give you a sense of a deeper sense, as I said earlier, of how a learning health system actually can be a significant agency for health improvement. A little bit of autobiography here. Oh, by the way, let me begin. When I'm talking, can you see me?
Yes.
Okay, good. And you should be seeing me in a little corner of your screen. So just a little bit of autobiography. I was a career academic until around 2003. I had been a faculty member at the University of North Carolina and the University of Pittsburgh. Around 2003, I wandered my way into the federal government. I won't belabor you with the details of how that happened. And then in 2007 through 2011, I was the deputy director and then chief scientific officer of the Office of the National Coordinator for Health IT. And it was there that I discovered the concept of a learning health system that around 2007 had been introduced by the Institute of Medicine, part of the National Academy of Sciences. What was then called the Institute of Medicine is now called the National Academy of Medicine. At that time, I was very impressed with this concept of the learning health system and was able to convince David Blumenthal, the national coordinator for health IT at the time, that learning health systems really should be considered to be the end goal in the nation's investments in health IT infrastructure, most notably, but not restricted to, electronic health records. And David agreed with me, and we really made this a priority project of the ONC, and that resulted in several things. An article that appeared in I'm blocking on the name of the journal, Science Translational Medicine, several monographs that came out through the National Academy of Medicine. And then after I left the government and came to the University of Michigan in 2011, I remained involved, and in fact more involved, in activities to promote learning health systems, including a national summit and the development of a consensus learning health system core values document that in turn resulted in the formation of a not-for-profit called the Learning Health Community. I'll mention that briefly again. In 2013, the National Science Foundation asked me to organize a workshop on the research challenges underlying a high-functioning learning health system, and that work resulted in a paper that appeared a few years later. And then in 2014, something rather extraordinary happened. I was given the opportunity to begin the first academic department focused on the sciences underlying learning health systems. And we called this department in the medical school Learning Health Sciences. I remain chair of that department. And the department did several things and continues to do several things. It started a doctoral and master's and now online master's program in health infrastructures and learning systems. We publish a journal called Learning Health Systems out of the department. I became involved with Harvard University's certificate program in safety, quality, informatics, and leadership. And that program is, I'm sorry, centered on the concept of learning health systems. And the department also spawned a very, very important initiative around computable biomedical knowledge called Mobilizing Computable Biomedical Knowledge, which is really trying to fill an important gap in the work that is being done around the country and around the world to achieve some of these challenges of creating high-functioning learning health systems that were identified in this paper. So this is just a quick background on me, and really what you're going to hear today is very much an outgrowth of all of these experiences that I have had with learning health systems over the last now 13 years. So there are going to be two main topics in this introductory talk. In the first, I'll be talking about what learning health systems are, while you will be seeing this filtered through my personal lens, what you also will be hearing is my own personal synthesis of not only my own experience, but also many other people's experiences and writings, and most notably material that has appeared in the journal that is now in its 6th year of publication. In the second part of this talk, I'm going to address a question that, if you did not ask me, if I did not bring this up, this is a question that I'm certain you would be asking me. And the question is, what makes this learning health system approach to health improvement different from other approaches? Some of these ideas have been around for quite a while. What's new here? What's really different? And you're going to see that I think there are 3 key differences: the embracing of uncertainty, the notion of multi-stakeholder learning communities as the drivers have changed, and this very important concept of infrastructure without which learning health systems could not function. So that is that, and I'm sorry for what's going on with my voice. I'm doing the best I can here. So let's move on with introducing a definition of learning health systems. And here is one of the shorter definitions that's around. You'll find a lot of longer ones, but I do like this one. And it goes to the idea that a health system, any organized entity designed to improve health of any size and any level of scale, can become a learning system when it acquires the ability to continuously, routinely, and scalably improve health by marrying discovery and implementation. I think that definition captures the essence of what it means for a health system to be a learning health system. I'll point you now to some literature, a lot of it that's around. One is the multiple books and monographs that have been produced by the National Academy of Medicine, and you can find downloadable versions of them at this URL. And then I can direct you to the Learning Health Systems Journal, as I said, now in its 6th year of publication. And this is a completely open access journal, and all articles that have been published in the journal are available for download at no cost. It's a completely online open access journal. Now, getting into the heart of the matter, you might have heard the terminology learning healthcare system being used, and it's fine, and I have no great objection to it. But I want to point out to you that really a better nomenclature would use the term learning health systems, because if we are going to improve individual and population health and reduce disparities and address other serious problems with our health system in this country and around the world, we've got to look beyond just the process of health care, which really, in a literal interpretation, only invokes the interactions between licensed professional care providers and recipients of that care. So I think learning healthcare systems underscopes what's possible, and I prefer that we use the terminology on top. There's actually a very nice essay by my colleague Aziz Sheikh from the University of Edinburgh in the journal that makes this point in a bit more detail and much more eloquently than I just made it. Another way to think about learning health systems is to think about a parade. And when people march in a parade, they often sing. And it's worth to get a sort of gestalt view of what a learning health system is, to think about the songs these hypothetical marchers in this hypothetical parade might be singing as they march down the road. And I've yet to be able to find a way to put these to music, but I'd very much like to do so. So if you're musically inclined, please get in touch with me if you have some ideas. The first anthem might be entitled, "Bring Us the Tough Problems." To my way of thinking, learning health systems are best applied to problems that are wicked, that have proved refractory to previous efforts to solve them, that are system problems, that don't have a single cause that can be identified. So the learning health system parade would be characterized by people singing "Bring Us the Tough Problems" as one anthem. It kind of follows that another anthem they might be singing is "A system problem needs a system solution." That kind of almost sounds like a song title. And a system problem, as I said, is ones that have multiple causes. And you are not going to solve those problems. You're not going to make people healthier with a one-dimensional or simple solution. You're going to have to address the system that is the source of the problem. So a system problem needs a system solution is another anthem the marchers may be singing. And then the last one, this is another one that could be a song title, 17 years to 17 months. And what this refers to is, some of you might be guessing, is the well-established many year, whether it's 10 or 12, 17 or 20, doesn't really matter. Everybody agrees it's many years of latency between the time new biomedical knowledge that could improve healthcare is discovered and its widespread implementation in practice. People like me who believe in learning health systems and the methods it implies believe that this latency can be reduced by whole orders of magnitude of time using these methods, 17 years to 17 months, and then maybe even further, 17 weeks to 17 days. And in the case of a public health emergency, requiring a rapid response to what is always a system problem, even 17 hours. So bring us the tough problems. A system problem needs a system solution, 17 years to 17 months. These are anthems that the learning health system parade would be singing, the people in the parade would be singing as they march down the road. Now, getting a little more specific about what a learning health system is, we can do another hypothetical. This is a little less zany than a learning health system parade. This gets to something that is more likely to happen in the world. Think hypothetically about an inspector who has come to visit a health system to determine to what degree that health system is a learning health system. And of course, we all know that inspectors carry clipboards, and clipboards have checklists. So one way to think about what a learning health system is to think about what are the high-level items that this inspector would have on their checklist. So one, I would argue, one high-level item that the inspector would be looking for is whether this health system can capture what it does as data to learn from. Does it capture its own characteristics? Does it capture events? Does it capture the context in which these events occur in the form of data that can be analyzed and thus learned from? Item number one on the inspector's checklist. Item number two on the inspector's checklist, if this data is analyzed and thereby turned into knowledge or evidence, is that made rapidly available to support solutions by people in the health system, to support decisions by people in the health system. And this does not only mean decisions by care providers, this also means decisions by patients, family members, by managers of the health improvement process. If all you have is data and you don't do anything with it, then you can't meet checklist criterion number 2. Criterion number 3, does the health system do these things continuously through, as you'll see, ongoing cyclic activity? We'll talk a little bit about what a cycle looks like in a moment. But is this a continuous and enduring process? I would argue that any health system can turn into a learning health system for a period of time when, for example, it's threatened with a loss of accreditation or some kind of financial exigency. But that's not what a learning health system, it's not a learning health system if it goes back to the former way of doing things after the crisis is over. So this has to be something that the health system does continuously. Fourth, here's that word infrastructure again. Is there an infrastructure in place to enable the above activities to happen routinely and with economies of scale? We'll return to infrastructure later in the talk. And finally, the inspector would be trying to determine whether all these things above are part of the culture. And one might think that if the inspector goes around and asks people, for example, why do you do these things? If it really is part of the culture, what they'll say is, I can't really tell you. This is who we are, and this is what we do here. It's almost like if they have an answer, if they say, oh, because my supervisor requires me to do it, that would suggest that this is not part of the culture. A very interesting 5th point. So these are the 5 checklist items, the 5 criteria at a high level of abstraction that the inspector would be looking for to see if, in fact, or to what extent this health system has the ability to improve health by marrying discovery to implementation and thus function as a learning health system. You get a kind of gestalt impression of what a learning health system is. Sorry, if you pull the keywords out of the checklist items I showed you on the previous slide and make a kind of one-dimensional Wordle out of it. People, it's really about people, learning, data, trust, knowledge, rapidity, performance, continuity, cyclic activity, infrastructure, culture. These are all key aspects of what a mature learning health system is. It's important to recognize, and this is one place that the systemic nature of learning health systems comes into play, that learning health systems can exist at virtually any level of scale. Single organizations can be learning health systems. Single organizations can come together to form a learning network, often focused on one particular set of health problems. Learning networks are becoming increasingly common. Excuse me. States, provinces, and regions can become learning health systems that are jurisdictional in nature and defined by their geographic boundaries. An even larger scale jurisdictional system would be an entire nation. And here you see Switzerland. And Switzerland is one of a few, but growing number of countries that have in place government-sponsored national scale learning health systems. And then there are those who would dream of a global learning health system someday. What is interesting about this and goes to some of the systemic aspects of learning health systems is that no matter what level of scale they occupy, they basically work the same way and do the same things. And we'll return to this point very likely in some way in this workshop. But just keep in mind for now that learning health systems can exist at any of these levels of scale. Okay, so if learning health systems have these characteristics, well, how do they improve anything? And they improve things by implementing a learning or improvement cycle that can be represented diagrammatically as shown on this slide. And the learning cycle will be the focus of our simulation exercise later in this workshop. The learning cycle that is employed in learning health systems has some unique features to it. That said, the concept of improvement via cyclical activity goes back probably 100 years. So this idea of an improvement cycle is certainly not new. What is novel here is the particular twist or spin that the learning health system approach puts on this. And one important feature, and this is where learning health system and learning cycles start, is with the formation of a multi-stakeholder learning community that is passionate about the solution of some health problem of interest. And as I said earlier, it is very often the case when these methods are used, this problem is some burning platform or serious wicked problem that is a system problem that requires a system solution. After the learning community forms with intent to address this health problem of interest to them, they begin by capturing current practices data. What happens now? And remember, I said earlier that one of the characteristics of a learning health system is the ability to capture what it does as data. So right here, this is what happens. And not only that, at this point, the measures, the metrics that would be associated with success relating to this health problem of interest would also be identified and measured for the first time. You're going to see a more concrete example of this in a moment. Then, as the cycle swings from the performance to data green phase to the data to knowledge blue phase, the data that are captured here are assembled in a form that makes them amenable to analysis. They are then analyzed. The data are analyzed to generate evidence that reflects the work of this learning community. This evidence is then combined with evidence that exists outside the work of the learning community. And it's almost always the case that any problem that is important enough to become a health problem of interest to a community has been studied by somebody else, maybe somewhere else, and often this will be in the literature. And this evidence is combined with the internally generated evidence to create a set of results that the learning community will come together here at the 12 o'clock point of the learning cycle to interpret and decide if enough was learned to generate ideas about what kind of intervention, what kind of change in the system could bring about improvements that were not known before this learning cycle started. At this point, the cycle swings into the red phase, the knowledge to practice or knowledge to performance phase. The intervention is designed. Whatever action is necessary to implement the intervention is taken. And at that point, the cycle swings into the beginning of its second iteration. The system now has changed because this action has been taken to change it. The metrics that are indicators of success will be measured, and the new data about how the system functions now will become the seed of the D to K portion of the second iteration of the cycle. So what is learned and applied here to create change and possibly improvement will be the seed of a second iteration leading to further improvement. So this is the learning cycle in general. To make this a little more specific, we can just take a very important problem, and I'm going to pick one, and this is also going to be the problem you're going to use in the simulation. How do we prevent falls in nursing homes? Obviously, a very, very serious health problems with great implications for morbidity and mortality around the world. Well, this would start with the formation of a learning community, people representing multiple roles in the health ecosystem from a number of nursing homes, and these could be nursing homes in a region or a state. These could be nursing homes owned by one particular company, or these could be a self-organizing group of nursing homes that's just interested in working to improve against this problem. The P to D component of the cycle would start by capturing practices data. What do these nursing homes do now to prevent falls, and what is the fall rate and their severity? Key metrics here would be determined. Now, the data would then be assembled from participating nursing homes, and everybody who does this kind of work pretty quickly realizes that assembling data that come from different sources to make them amenable to analysis is not a trivial task. The data would be analyzed, and one of the results of the analysis might be practices at some of the nursing homes that are associated with lower fall rates or lower severity, or the opposite in the nursing homes that participate. Needless to say, there is a great deal of external evidence in articles and other sources about this problem, and then the community would come together, look at the external evidence that's been gathered and the internal evidence that's been gathered from the data at the nursing homes participating themselves. And the community would say, well, what have we learned from this, and what interventions might be indicated to make things better? Understanding that these things were not known at the time the process started. These things had to be discovered through data collection and analysis. The community would then design the intervention. What's it going to be? How's it going to be implemented? Or maybe they want to do an experiment to do it 2 or 3 different ways and see which one works better. They would then take action to change current practice in whole or part at each of the nursing homes. And after that action has been taken, they would be capturing new practices data. What does each site do now that things have changed? What is the relationship between the new practice at each site and its fall rate? And what is the fall rate and severity across the sites? And have things gotten better as a result of the intervention? And if so, why? And if so, why not? All of this can be learned from the analysis that begins here. Key point to emphasize, and a key differentiator that we will return to, is that the community that discovers is also the community that implements. I come back to the importance of the formation of a learning community and the idea that this same community follows the entire cycle, P to D, D to K to P, back to P to D, as the cycle repeats itself. And just to give you a few contrasts, my main point here is that better health requires this complete cycle idea, and not what most of us, including myself, were taught to do at the beginning of our academic careers. We were taught to collect some data about a health problem of interest, analyze it to create new knowledge or evidence, publish it in a journal, and then go back and collect more data. Maybe it's data about more data about the same problem, or maybe moving on to a different problem. Convert that to knowledge through analysis, publish that in a journal, and then so forth. And the assumption being made when you do this, of course, is that there's someone here waiting to take that knowledge and put it into practice. But I would submit to you all that one of the problems one of the reasons we have this 17-year latency between discovery and implementation is too often there is nobody home here, and these results languish in journals too long before they are finally implemented. So this, not this, in a learning health system approach. We also don't want to do this in a learning health system approach, and this is what I call the interrupted cycle or the fragmented cycle. And this occurs, and this happens at many institutions, I'm sorry to report, when instead of one learning community following the whole cycle around, the improvement cycles are implemented, but each component of the cycle is undertaken by a different group, each with its own leadership and governance, and each with its own culture, so that to complete the cycle, there needs to be a handoff. And in coming from Michigan, of course, I'm very well steeped in football and know that when there are handoffs, there can be fumbles. And in too many cases where these kinds of cycles are implemented, and these are different groups who do P to D, D to K, and K to P, there are missed handoffs and there are fumbles, and even when there aren't, things don't go as well as they would if this was a continuous process followed by the same community. To close out this part of the talk, I will point out to you that this idea of learning health systems really has taken hold in the past few years across the country and around the world, and we're seeing it with the exception of a global health system at all of these levels of scales I talked about before, single organizations. And in the US, I would really single out Intermountain Healthcare and Geisinger in Pennsylvania and the Mayo Clinic as three examples of learning health systems in the US, but there are many others in progress. I've tracked about 14 major academic health centers, not listed by name here, that have learning health system initiatives in place, many of them through their clinical and translational science institutes. There are many, many learning networks around. A lot of them spawn through PCORI, the Patient-Centered Outcomes Research Institute, PedsNet based in Philadelphia, CancerLink of the American Society for Clinical Oncology. There's a national NIH-sponsored early psychosis intervention network called EpiNet, and there are several ARC initiatives designed to promote learning health systems. There are statewide and provincial initiatives in North America. And then there are nations, I've mentioned Switzerland, Scotland and England in the UK, Saudi Arabia, and in our own country through the Veterans Health Administration that are national scale learning health systems initiatives. A global learning health system maybe someday, but I would just editorialize to say that COVID-19 certainly, when you think about it, or at least when I think about it, has issued a clarion call for a global learning health system. Just to give an example of a sort of collateral validation of what you heard today, in the UK, there is something through their Health Data Research UK initiative, the Better Care Partnership, which specifically says, although they say learning healthcare, they're with the program here. We support the development of learning healthcare systems that integrate practice, data, and advanced analytics in a cycle of continuous improvement. And what you'll see here is their vision of a learning cycle, which is quite closely resembles the one that I showed you. Okay, we're through the first half of the presentation, and I'm going to stop sharing my screen, and I would like to pause now for questions or comments. Please raise your hand and I will recognize you. And it is not acceptable to have any questions or comments. So please step up and tell me what you think or what further you would like to know.
There is a question in the chat, a comment question from Heather Martin.
Yeah, Heather's here and she's waving at us.
Oh, there we go.
Go ahead, Heather.
Hey, this kind of has to do a little bit with the 17 years bench to whatever you call it, bench to bedside, and just other types of ways that you can disseminate besides publication, especially internally in the health system. We're just having problems with initiatives that are going well, and we're not at capacity because clinicians across the health system aren't aware of it. And if anyone has had success, if you have like a really kind of siloed health system, if you've had success with dissemination initiatives across your health system, what are they?
Well, my response to this, Heather, would be to focus these improvements through a community focused on improvement in a particular area that is committed as a community to follow this whole cycle around, which includes implementing whatever they discover and agree needs to be done. Your scenario sounded to me a little bit like that broken or interrupted cycle where somebody has come to the conclusion that there's knowledge out there, there's evidence out there to suggest useful ways to change, but you can't get over that barrier, you can't get over that gap in the middle. And I would submit to you that using the community mechanism is a way to do that, because this community at the outset is pledged not just to discover, but also to implement.
So can you make that a little bit more tangible when you say community, like we're just getting a LHS off the ground, and it's been a lot of getting the right people in the right positions for political hurdles and things like that. And when you say community, do you mean like we have a website, like getting people to partake and be membership, and then we put things on there? And is that an example of a community?
Yeah, and they would meet, and actually they would make all of the decisions about what is going to be done. I'll get into this in a little more detail, but it's a concept that comes out of the idea. You may want to read some of his work, of Paul Batalden, who has developed this notion that care is is best if it's co-produced. And the community embodies this notion of co-production. Patients, providers, administrators, others come together and make these decisions together, but from the outset, they are committed to implement, not just discover and publish in a journal.
I understand what you're saying. There's just, we're a long way from that, where we are right now, but I understand what you're saying.
It's a journey. And I'll show you some examples. It's a journey, but if you're going to solve a tough system problem, you have to put the sweat equity into it. And maybe I'm describing a form of sweat, what the sweat equity looks like. Do we have other hands raised? Abdul.
Maybe a suggestion, it's not a question. You say tough problem. If you're talking about a system languages, they call it a messy problem, or mess. The system is a mess. Then you tackle that mess in terms of the system theories. And my question is that do you have a desired outcome within your system? And if you don't have, then how do you know you learn?
Oh,
How
yeah,
do you know that you have a tools for intervention, or you have the problem you had before, or the solution you had before is not good enough for you, therefore you need a new solution. So,
right. Yeah, let me go back and share my screen. And so I'm not just waving my hands here to answer you. I want to come back to a point I made here. Here in the preventing falls in nursing homes example. Well, let me go back. In the general cycle, what you do here when you're capturing practice as data for the first time you go through the cycle, the community must determine what are going to be the metrics of success. And not only does the community here determine what would be the metrics of success in the first implementation of the cycle, they actually measure how well they're doing now. So yes, this is directed by a very clear sense of what the metrics will be that define success, and as metrics they have to be measurable. So this isn't a random walk through the desert of health improvement. It's goal directed. Now, that doesn't mean the community discovers that the committee won't discover other metrics or unintended consequences or things like that. But at the outset, there's a core set of metrics and a core goal.
Is that easy to say that it's similar to the control system problem or cybernetic problems and something like in engineering? Is it?
Yes, yeah, and this is an amalgam of a lot of concepts that come from a lot of different fields. But thank you for that comment. Okay, Elham.
Yes, hi, thank you. Just a brief introductory. I'm a health economist and working with our EMR system and faculty from Department of Learning Science to develop this predictive tool of readmission among specific cohorts. My question is, one issue that comes up is generalizability. As you mentioned, it can be just institutional data, or we can expand that. And that's an issue that especially funders point out to. Do we have any mechanism at this point to merge our EMR data with other institutions, at least make it multiple institution in a single one?
Yeah, and so I'll go back to the point I made about learning systems existing at multiple levels of scale. And I think that you have made the argument to form learning networks and do things across institutions. And then you get the perspective, and of course you get larger numbers to learn from with all the benefits that large numbers bring, but you also get the benefit of diversity and other benefits. So of course, some individual organizations are so big that they have the scale and the diversity to do this on their own, but learning networks are growing faster than I can keep track of them, actually, for just the reason you were saying.
So is there, I mean, yes, there are organizations like, for instance, Kaiser Permanente, that they consist of so many organizations and they can afford doing that. At this point in time, if I want to, I'm just asking a practical question and a selfish question for what I'm doing. At this point, if I wanted to use what I've learned, should I approach different institutions at a personal level to see if I can use their EMR data, or do we have anything in place, or strategic move forward to combine these EHR data, if you will?
I come back to a more general point from my perspective, that if you invest in forming a network, it's difficult and it's challenging, but it's an investment that pays dividends, because a network of institutions that form maybe initially to address one problem can use that same infrastructure and that same apparatus that it develops to address other problems. Ad hoc partnerships can work quite well, but to my way of thinking, if you're going to put in the effort to form an ad hoc partnership, why not form a persistent and durable network that can be a gift that keeps on giving, so to speak.
So is there any, how can we expand upon that, basically? Is there any effort at this point to do so? Whom should I reach out to see?
Well, there are a lot of networks around already. I don't know, what institution are you at?
Michigan Medicine.
Oh, okay. Well, you come talk to me. I can introduce you to a number of networks that are around already. And if, for example, our CTSA, MISHAR, has a network-based research unit that's in the business of doing network-based discovery. Come talk to me and we'll talk about it. Okay.
Perfect. I'll send an email afterwards.
Okay.
Thank you.
All right. Well, we're going to move on. Kathy, did you see any juicy questions?
There are questions in the chat. Bridget McDaniel has, she wants to know challenges, where do you find the most challenges arise within the cycle? At which point?
Well, there are challenges at every point, I should say. But I do think the challenges that primarily arise are in the knowledge to performance area, because inducing change is hard, and we don't know as well how to do that. There's a field called implementation science that relative to the discovery fields, the data to knowledge fields, is relatively immature, although it's growing. I just think the combination of the difficulty of changing anything, particularly if people are invested in the way they're doing things currently, coupled to the less mature science of implementation relative to the more mature science of discovery, puts more of the challenge on that side. I'm going to go ahead now and move into the next part of the talk to keep us on track. When we get into our wrap up, I hope we'll have time. We can return to some more of these questions. Okay, do a fast forward there. Okay, so what makes the learning health system approach different from other approaches? And I said there are going to be 3 points that make this larger point. And the first one is this notion of embracing uncertainty, requiring discovery. If system problems are complicated problems, it follows that at the outset, this learning community, which forms down here, is going to be unsure of what to do. And in fact, it's going to be discovering what's happening now, how should we change, and how should these changes be implemented really throughout the cycle. You can think of the whole cycle as a process of discovery. And as I mentioned, that this discovery process is undertaken in a collegial way by members of the learning community that really co-discovers. Everybody participates in this process. But the key point here is at the outset, you're not sure what you're going to do. So it's very important, therefore, that the learning cycles start here at 5 o'clock on the clock face and go into the P to D and D to K of phases, and not at 5 o'clock. And not at 5 o'clock, and not at 12 o'clock. If the learning cycle starts at 12 o'clock and you begin with the implementation of something, the community has either been told what to do or has made a kind of evidence-free decision. They get together and say, well, all right, well, this is what we think we should do, but we're not going to base this on any evidence. If the cycle starts at 5 o'clock, which is what we advocate, then the community begins by acknowledging that at the outset, it does not know what it's going to do to improve against this health problem, and collaboratively discovers what to do by working its way around the cycle. So going back to our nursing home example, if the cycle were starting at 12 o'clock, the starting verbiage would be, well, based on advice from our consultants, the leadership of the organization has decided that the following changes will be implemented to reduce falls. And what the community then is charged with is basically to make it happen, but they've been told what to do. At 5 o'clock, it's a different question, or a different starting point. The leadership is concerned about the rate of falls based on your own experience and the literature. Remember, discovery, internal, external literature coming in from here, develop and implement a plan. So that is the LHS approach, the learning health system approach, as opposed to what I call the anti-LHS approach, which is to start at 12 o'clock with having been told what to do or just deciding what to do without any evidence. Point number 2 about differentiators is this idea of multi-stakeholder communities. And I've made this point already in response to some of the questions that have come up. You want this community to conduct continuous cycles, meaning that the learning community follows around the whole cycle, just kind of changing color, so to speak, doing the green stuff, and then the same group does the blue stuff, and then the same group does the red stuff. Now, at each stage of the way, the community may want to bring in as advisors, specialists and consultants, but the same core group as the community changes color as it moves through the cycle will be participating all the way through the cycle. And what you don't want is this broken model where people may be called program evaluators are the ones who do the performance to data. Different people who are called embedded researchers, for example, do the data to knowledge, and then change implementers do the knowledge to practice. And these are, in this broken, interrupted cycle model, are completely different groups of people with different leadership and different cultures, as you might expect. This is not the way to implement change according to the unique ideas that underlie a learning health system. So you can't skip this step. I talked about the sweat equity, forming a cohesive learning community is a journey and it can take time, but it is an investment, as I said, that pays dividends, because in return, you get this cohesive multi-stakeholder group that follows the entire cycle around. And as I've said already, these communities are collaboratives. All the stakeholders are at the table. They're passionate. They share a passion to achieve the health performance improvement goal, which has been identified. Everybody participates in decision-making and strategy generation. The leader must be a facilitator and not a dictator. And no single group can dominate a learning community. Otherwise, its collegial nature completely falls apart. Now, there are some terrific examples out there, and one of them is a network called Improve Care Now. This is based at Cincinnati Children's Hospital, and it's a now pretty much a national network that uses all the principles I've described to you. Here is an example, and I think this shows you that this can take time, of what the focus on inflammatory bowel disease that Improve Care Now has yielded against the goal of increasing the remission rate for adolescents and young adults with inflammatory bowel disease. And you see an increase from something around 50% to something approaching 80% in about 8 years. There's a reference here on this slide if you want to read the full paper. So Improve Care Now has basically taken the methods I just described to you and put them to work. Here in Michigan and working in Washtenaw and Livingston counties, we have focused on a very, very wicked problem of increasing the survival rate from an out-of-hospital cardiac arrest from something under 10% to at least double to a goal of around 16%. And to do this, we formed a learning community, and we spent a lot of time doing it, bringing together stakeholders across the whole chain of survival. That as the American Heart Association has framed the problem and the challenge of addressing a health problem that results in the deaths of 92% of the people who have it. And this effort in Michigan has gotten the attention of the American Heart Association, who now, through a grant to the University of Michigan, is funding this effort. And this is what a learning community looks like. What you see is a group of people who meet periodically. They discuss problems, they make decisions. You see the multi-stakeholder nature of the community here, the broad participation. And here's a picture of a cardiologist some of you may know, Brahmaji Noamothu, a victim of a cardiac arrest who survived, and the survivor's daughter. So everybody's involved in this community. Next is this idea of infrastructure, which enables scalability. And the point here is that these learning cycles I've talked about do enable improvement, but they don't create a learning system. In other words, if every learning cycle directed at its own health problem going on in some environment really is a do-it-yourself tub on its own bottom, you can have learning and you can have improvement, but you don't have a system. So by analogy, think about a city that is bisected by a river, as many cities are. And if you want to get a lot of people across that river every day, you can do this in an anti-infrastructural way and get everybody to build and their own rowboat and row themselves across the river. This is the complete anti-infrastructural approach. Or you can build a bridge that everybody can use, and obviously a bridge is a quintessential form of transportation infrastructure. The way this projects itself onto a learning health system is to think about a learning health system, seen up here in bold italics, because this is what makes it a system. It's a collection of learning cycles going on at the same time, each addressing its own problem and each cycling at its own pace, slower cycling here, more rapid cycling here. However, in this infrastructural idea, all of these cycles are sharing and getting supported by a set of services that are provided to all of the cycles. And the reason services can be provided that are kind of like what a bridge does for transportation is that each of these cycles, even though it's addressing a different health problem, is still doing basically the same thing. The green P to D, the blue D to K, and the red K to P. And it's important to recognize that a infrastructure supporting a learning health system, although technology and information technology is very, very important, the infrastructure has to address more than technology. It needs to address people, it needs to address processes, and it needs to address policies. Why do you need this? You need this because if you don't have it, there's no economy of scale. If every cycle requires its own agreements, technology, staffing, analytics, and dissemination mechanisms, the cost of doing 10 cycles is going to be exactly 10 times the cost of doing one. There's no economy of scale. But with a platform where all the cycles are supported by a shared infrastructure, there's big economy of scale, and the cost of doing 10 cycles is going to be far, far less than 10 times the cost of doing one. The infrastructure provides services that all of the cycles can share. So what are these services? This is a very important topic that we can only scratch the surface of today. But to see what these services are, take this diagram that I showed you and imagine yourself looking down on it from the top. And if you look down on it from the top, you see the infrastructure here, and you see these concurrent learning cycles here. And you can think about services that align with each stage of the learning cycle that can be provided in a generic way. Services to organize, start, maintain, and support learning communities, services to measure performance, services that help represent health information as data, services that make knowledge computable and shareable, and so on and so forth, that can be provided much as a bridge can support many, many modes of transportation and many, many people. These services as infrastructure can support collectively everything that a learning cycle needs to do. So in closing, I made 2 points today that are primary. What are learning health systems? A short answer is learning health systems improve health by marrying discovery to implementation, which drives further discovery, which drives more implementation, and so on and so forth. And that the learning health approach to improvement differs in 3 major ways from other approaches. This notion of embraced uncertainty, that the community does not know at the outset what it's going to do, it has to discover it. The idea of multi-stakeholder learning communities that enable continuity around the cycle, so there are no handoffs and no fumbles, and this idea of infrastructure, that there are shared services enabling scalability, making cycles into a system. There's some relevant publications that I can suggest to you. A lot of the ideas in this lecture are in these 2 articles. And finally, I can recommend to you literally everything in the Learning Health Systems Journal. 6 years of papers, and I'm delighted to report that in 2021, 100,000 papers in learning health systems were downloaded 100,000 times. We reached a milestone with the journal last year. So, we're not going to cover everything today, and you may have questions that arise afterward. I encourage you to write to me at this address, and I'll be happy to write back to you. We're going to take a short pause here, and we'll take a short pause here. I'll stop sharing my screen, and we will entertain a few more questions before we move on to the simulation exercise? Raise your hand. I'll recognize you.
Thanks, Chuck. What are some of the bigger successes that we've seen at the Michigan Medicine applying this strategy?
We've got in the institution the Department of Physical Medicine and Rehabilitation, PM&R, has dedicated itself to becoming a learning health system at that level of scale. And Ed Hurwitz and Claire Kalpashian in PM&R and their colleagues are really leading the charge, and that is something I can point to. The out-of-hospital cardiac arrest effort has been underway for about 3 years and is chipping away, as I said, at a very, very wicked problem. The Department of Radiation Oncology, the work of Chuck, I'm blocking on his last name, help me.
Mayo,
thank you.
Yep.
And his colleagues are exemplary of learning health system methods. And something that's just starting up, Melvin McGinnis and colleagues in the area of bipolar disorder they're getting learning health system efforts underway. In pediatrics, Joyce Lee has been named the Associate Chair of the Pediatrics Department for Learning Health Systems Initiatives, and she has interesting and important work underway there. So there are at least 5 departments that have a very significant learning health system efforts underway. And as always the case in Michigan, because it's so big, there are always things going on that nobody knows about or no one person knows about. But there are 5 good examples.
wonderful, thanks.
Okay, Rajiv.
Thank you. One thing that we find frequently when we talk of change and implementation and an implementation science, and that is we do a pilot, but when we try to scale it up, things don't work as well as we would like them to, or as well as they worked during the pilot phase. Do you think the learning health systems methodology can help us in translating and scaling whatever has been discovered during a pilot, taking it across the organization or taking it across multiple organizations?
A very good question. I think the focus of improvement will be the magnitude, the coverage of the improvement will be at the scale of the effort. So in other words, in my nursing homes example, if 17 or 30 nursing homes participate, that will be the scale of the improvement. And the pilot is more a pilot in time through the first cycle than it is a pilot in scale. In other words, the scale is initially set, and then and the improvement occurs at that scale, and each cycle is kind of a pilot for the next cycle, so to speak. So it's a very different way of thinking about it, and the idea that, okay, you have 17 nursing homes in region X, can the 22 nursing homes in region Y do the same? Probably they can learn and adapt to their own circumstances. A lot that was generated in the original group, or they may come together and form a larger network, and successive cycles will be done at their larger levels, at a larger level of scale. So it's kind of a different way to think about what you mean by a pilot, for all the reasons that you described. If an initial pilot is really small, no matter how successful it is, it may be very hard because of factors you didn't take into account at the start, because they're particular to where to the pilot, to make whatever it is work on a larger scale.
Thank you.
Okay, any other questions at this point? Okay, we'll move on now to our simulation exercise. I think you will enjoy this. And I will share my screen again. And here we are. And so we're going to do some quick overview. That's what we're doing now of the simulation exercise. We'll then get you into groups, and then we'll come back and have a full group discussion. Okay, so you're going to be designing many components of the learning cycle, and you're going to be using this example as of preventing falls in nursing homes as the problem of interest. And you in the simulation, your group is going to play the role of a learning community, and you will experience, as well as we can do in a 1-hour simulation exercise, the experience of going through an entire cycle. So we've created breakout groups that we will very soon, randomly, of about 7 participants in each group. As I mentioned, you're going to design many elements of a learning cycle. Now, a task instruction sheet and a recording sheet were mailed to you in advance. What I'd like you to do, if you don't have those materials in your possession, access to them now, put your email address in the chat, and Kathy will email them to you. So let's take a second to give people a chance to do that. Are any addresses appearing in the chat?
I have already sent to several people, because I
Okay.
also put in a chat message, Chuck. I wanted to say, though, we're supposed to take a break before the breakout sessions. We have a
Okay.
break,
Okay, well, we can take a break.
unless, well, it's on the agenda, that's why.
Okay, well, I didn't put it on the agenda that I showed before.
Oh,
Okay, all right, before we get into groups, why don't we take a 5-minute bio break, or whatever kind of break you want to take, and we'll resume at 2:28 Eastern Time.
and if anyone needs those documents, please put it in the chat and I'll send them to you right away.
Thank you.
So we should be back at 2:30.
I said 2:28, but 2:30 is
Oh,
fine.
okay.
Round it off,
You're always so precise. All right.
always.
Always. All righty, cool.
I'm afraid I have to leave. Thank you.
If you come back during, and then we're already in the breakout sessions, I'll be in the main room and I can always assign you if anybody comes back.
Okay, thank you.
All right. And then you also
Thank you.
get the recording and the slides. There'll be links
Okay.
sent out. Okay. Thank you for
Thank you
attending.
very much.
All right.
Thank you. I'm in UK at the moment, so it's just getting late here. So, ciao. Bye bye.
Bye-bye. Okay, well, we're at 2:30. I hope everybody's back. Kathy, do we have a way of knowing if people are back?
I just noticed that my mic is off. No, we don't know if people are back. We're assuming they are, but if somebody is not here, then we'll just, if we put them in the rooms, I'll just assign them as they come in, if they, come in late.
Right, but if they're logged in, you can put anybody who's logged in a room, whether they're physically.
Yeah, I can. I'm just saying if something goes wrong, I will be here anyway and take care of it.
Okay.
But I don't know who's back and who isn't. Some people have said so in the chat. Some
Okay.
people have had to leave.
Okay, well, we will proceed.
Yep.
I'm assuming that everybody is back and that everybody has, if they do not have the materials, have put a note in the chat so Kathy could send them. One of the documents that you have is a task instruction sheet, and the top of it looks like this. And this is a step-by-step set of instructions for what you were supposed to do to complete the simulation exercise. What you're going to do in the simulation is you're going to be talking about how to form a learning community. You're going to be talking about how to capture current practice as measurable data. You're going to talk about how to interpret the results, and you're going to talk about how to design an intervention based on the results. So this is a very time-collapsed simulation of the execution of a learning cycle. So we're going to send you into your groups in just a moment. When you're in your groups, I know we didn't do any introductions at the start of the workshop, but this is an opportunity to introduce yourself to others in the group. You're going to need to make two selections. You're going to need to select a reporter who can share their screen, and a moderator to facilitate the discussion and keep track of time. You're going to have 45 minutes to complete the simulation. You can then begin by working your way using the task instruction sheet step by step, which will lead you through the simulation. What I'm going to ask the recorder of each group to do is share their screen within their group, and using the answer sheet, which you already have, which has already been sent to you, the recorder will enter your answers in real time as your group generates them. And since the recorder will be sharing their screen, everyone will be able to see what the recorder is writing, and that will be a shared resource for the group. If you need help, you can use the help feature to alert the staff, and either they will help you or they will alert me. And as I said, you have 45 minutes for this exercise, and I think you're going to find this very, very helpful. And then we're going to gather at the end of the 45 minutes as a full group, and I'm going to ask several of the groups recorders by again displaying their screen by showing what the recorder has written for their group on the answer sheet. So this is how we're going to proceed. Are there any questions? Okay, Kathy, it looks like you're going to be creating about 4 groups.
That's what I was thinking of creating 4, but then I thought there's the 3 of us, so probably maybe best create 3 groups.
Okay.
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 All righty.
Okay, Kathy's going to put you in groups now.
Amber, you have to join, click join. And is Michael there? Hello, Michael. Jesse, could you click to join your room? And Amber? Maybe they're not at their screen. All right, I'm going to visit the rooms.
Okay.
Okay.
Kathy? Oh, Kathy, do you want me to go into certain rooms or are you gonna hit them all? Oh, because she's gonna go to them all.
Kathy, I don't have the capability to move from room to room. It's only letting me go into room 2. I think you assigned me to a room. You're on mute.
Yeah, I'm sorry. I have to make you a host so you can go, or make you a co-host. You want me to do that?
Yeah, please.
Okay, sure. Hold on a second. So I'm making you a co-host. And you'll be able to go.
Okay, thank you.
Don't say end meeting or anything, because you'll end the whole thing. Because you'll have,
Right,
okay, all right.
right.
We don't want to do that. Are you able to go now?
Yep.
Okay, cool.
Kathy, I couldn't either.
Right,
So if you want me to, but since, I mean, I was more concerned, I thought there'd be more groups, but then there's only what, 4?
right. Yeah, so I'm thinking if you want to pop in later, you can, but let's not have too many co-hosts.
Yeah,
You know, let's just let Chuck go in and have him come back, and then, you know,
yeah,
yeah, that's what I was just writing you that.
okay.
Yeah, I was texting you. It's hard to do 100 things at the same time. I unfortunately have a lot of email today as well.
Oh,
And I don't have the timer for the breakout rooms. I don't know why the timer isn't working. So I think they got in at, let's say like 2:35, I'm thinking.
yeah,
So I'm
And
gonna
one-
end it at 3:20 and I'll send a message at 3:15.
yeah, that sounds good.
Yeah, all righty. Okay. And I'll edit this section out of the recording, of course.
Mhm.
I think Jesse and Amber probably are not at their desks, so that's why they're not joining.
Mhm.
But group. So that's group number 2, which is the one that you're in, and that's where Amber's supposed to be. So see, this is the problem. Oh, Amber's, looks like Amber's in room number 1. Maybe she's logged on twice.
Yeah, I was gonna say, I saw a few people that were there multiple times. I
Yeah,
thought-
so Amber, see what happens then? That really,
Yeah.
that creates a big problem. So she's already in group 1, and that's why she's not in 2, and 2 only has 5 people, because
Hmm.
you're supposed to be in that group too. So yeah, these are, keep all of this in mind for the, you know, the workshop.
Mhm.
It's very hard to, I don't know how we'll pre-assign people. That might not work.
Yeah, we'll have to think about it. Plus, we lose people because I was noticing.
Yes, yes, that's what I wanted to say, is you lose people with the breakouts.
Did everybody stop talking when you came, Chuck?
I have that effect on people.
I don't see why, but I think that the teacher being in the classroom, you know, that's not the purpose of the room. The purpose is for the people to work on their own.
Yeah.
So that defies the purpose, kind of, is the, you know, the teacher being in.
Well, we're down to a real skeleton crew. We don't really have that many people still here. It's kind of disappointing.
It is.
Yeah, I wonder if that's why I really didn't want to give them a break. I think a lot of people used it as an opportunity to leave.
Yeah, but the agenda I sent them had a break in it.
Oh,
Yeah,
but the
that's what-
agenda I put on my slide.
Oh, well, see, that's the thing. So, like, so Lisa's like, well, aren't we going to take a break? I'm sure everybody else was thinking the same thing because they were looking at the agenda.
That's true. You're right.
So we had this happen, Chuck, with the learning community workshop too. Like a bunch of people left before the breakout session. I wonder if we should think about doing it all together. I know that's unwieldy, but maybe people would like it better if we did it all. I don't know. We got to think about that.
I think Lisa, it has an energy when the whole group is together. You see how they were very passionate in their comments, like in the chat, it's an energy, and then you're kind of, if you don't want to talk, you don't have to.
Yeah.
And other people can carry the conversation. I think that if Chuck had just kept going, that probably you would have had a lot of comments and the group would have been able to find a solution.
Well, yeah, well, okay, well, we can talk about it. I'm a big believer in small group instruction.
Yeah, it all depends though. Maybe it has to do with if it's not live, you know what I mean?
Well, I'm going to go back to the groups now.
Yeah, I think if you want to go to any groups, you should probably go to group 2 because that's the one that seems to have fewer people in it.
Well, group 2 has 8.
Yeah, but they're not in there because there's Amber who hasn't joined, but she's actually joined in group 1 because she's on 2 devices. And then Lisa's supposed to be in that group. So that's
right.
-2 people, and it's you who are supposed to be in that group anyway. So really they only have 1, 2, 3, 4, 5 people.
Okay, I'm going to go.
And that's where you're supposed to be anyway. You were assigned there, see? So it's kismet. You're supposed to be in 2.
Yeah, I'm thinking more about just maybe rather than, I mean, we could break them out at the beginning to do the icebreaker and the introductions.
Yeah, I think that's a nice thing.
Yeah, and then but do the exercise all together.
Yeah, he likes the small group thing, but I think that a lot of people, they don't like to talk. They don't want to they don't want to think too much, and I don't blame them. I mean, I personally, I don't like breakout rooms.
Yeah.
I don't like, these small group things. I like to be in a group and listen, and
Yeah.
That's just, it's a personal thing.
Yeah, I'm the same way. I don't.
And then you have like, if someone's on 2 devices, you've assigned them to a group.
Mhm.
And if somebody's gone, they're not there, but they've left their computer going.
Mhm.
It's too
Then
many
we-
problems.
Yeah, and then, if people don't want to stay, they can leave after the lecture, and then whoever's left, we can just do it as a big group. Then we don't have to pre-assign the breakout. I think that's the better idea.
And then you get the people who are invested.
Yeah, yeah.
Remember how when we had those post-session groups with the collaboratory?
Yes.
They were always very, very exciting because the people who were there were the people that really wanted the information.
Yeah. Yeah.
That one lady that asked the questions, Elham.
Mm-hmm.
Yeah, she might be nice. I looked at her. She's in, what do you call it? Oh, here's somebody's joining now.
Maybe group 2.
Yeah, that's what I was thinking. But it looks like they're having a hard time getting on.
Yeah.
Hello. See if we can unmute. Hello, Mahdi? Are you there? No? All right, no worries. Well, they got off.
Okay, they're getting into it. Kathy, how much time is left on the timer?
So the timer, according to when they went in, they're supposed to close at 3:20. So it's about 15 minutes.
They got 25 minutes. It's 2:54. Okay, we'll see how far they get.
Yeah, I'm gonna send them a reminder about 10 minutes beforehand.
Mhm. Yeah, they won't get through it all, but we'll,
Yeah, and then maybe you'll have time. There's quite a few questions in the chat if you want to
Yeah.
go through.
yeah, but there are very few people left, so yeah, we'll see. Yeah,
Yeah.
it's kind of a downer when 2/3 of the people leave. Um,
Yeah, that's what Lisa and I were talking about. But you know how when we would have those post sessions where the people that remained were the people that were really invested in it, and they had a lot of energy because everyone is interested. So maybe you might want to maybe do the workshop and then maybe cover some of the information and then get into depth with whoever's left as a group, and get the questions.
yeah.
The
So
Q&A, I
what
thought
was,
would.
what was the magic lottery number? How many were here
Well,
when we
I
started?
sent messages to myself. I couldn't take a screenshot, 'cause they would see me. So at 1:48, which was like an hour into it, it was like 49. So the max was like 49, but those people stuck around. And then there was at 1:09, when you first started, there were 45 people.
Okay, well, that's the number.
At 119, there were 48 people.
Okay, I think it's when I started.
Yeah, so
So it's 45, and
Yeah.
we subtract the 3 of us, so it was 42.
so you get to keep that freezer. I guess nobody got that number.
Well, we could give the freezer to whoever came closest.
Well, that's me, but I don't want it.
Who said the prize was a freezer? You guys
Did
said
you?
that.
I thought you said it was about a freezer in your basement. We were trying, and then Doug said that it was not cost effective.
Well, I was only kidding. I was only kidding about the freezer. Who knows?
Oh, okay. Well,
You
that
may have
that's
won
different.
you may have won a new Porsche.
Oh, gee whiz! I'll take an old one too. It doesn't matter.
Okay, all right.
Doesn't have to be
We'll see.
new.
We'll see what
Is your
we can
cough
do.
is your cough up here, or is it deeper?
No, it's allergies.
It's like a tickly cough.
Yeah,
Oh God, I hate those. Don't you hate that? That is the worst cough, like a pepper. Yeah.
yeah.
But you're feeling good. I'm so happy
Yeah.
you're feeling good. I got so worried when I read that email that you're, gee. It's good
No,
that you're
I'm-
feeling all right.
Yeah,
Wonderful.
except for the sneezing and the sniffling and the coughing. I feel
Yeah,
fine.
I think allergies are bad this year.
Yeah, I was talking to Gretchen. She said she's really suffering.
They're
too.
terrible, terrible. Yeah. It's just and the weather's so crazy that probably doesn't help it at all.
All right,
Yeah.
I'm going to go visiting again.
Okay, all right. Yeah, I'm here in case anybody comes. No worries. Hello, Katerina? And Emily, did you want to be assigned?
Sure. Yep, that sounds great. Sorry I had to step away, but thank you.
That's okay. Do you remember what room you were in?
I don't.
You don't? Okay, not to
Um,
worry. I'll put you guys in one room.
Okay, thank you so much.
All righty. So let's assign you to. Second. See if I can find you. Oh, here you go. All right.
So when you walk in,
Two. So Emily, I've assigned you as well. You'll just have to accept the, say join.
I see. Got it. Thanks so
Okay,
much.
awesome.
Thanks, Kathy.
Thank you.
Well, one group looks like they're going to finish.
Oh, good. They've got about 4 minutes.
Right. Yeah, I told the other groups not to sweat, that we'll kind of finish the exercise as one big group because there aren't that many of us.
When you're presenting, you want to sit up closer. I was looking at you. You were, because your face is like, see, you have to sit up like that.
Oh, I couldn't see myself. For some reason, when I when I checked the thing where I was supposed to see myself, it wasn't showing me.
Oh.
So I wasn't getting any feedback as to what I looked like.
Oh, okay. Because you were down low, and then where your name is, it's like right over your face. That's the problem, see?
Oh, I got no feedback at all as to where I was.
Oh, okay.
And I don't know why that was the case, but that's why I asked. That's why I asked if you're seeing my face.
If you could, yeah. No, you were fine.
Because I wasn't seeing my own face. It was very weird.
See, that's the difference. The webinar is nice because you only see the speaker. You don't see everybody else, you know. You could just put speaker view. I mean, when you're, you know, I mean, I could change it to speaker view and not have the gallery view.
Well, I had it on speaker view, but it wasn't showing me.
Oh, but maybe were you talking when you were looking?
Mm-hmm.
Oh, okay. Yeah.
Yeah, I was wondering about that. I was wondering if I was centered, but I had no way of knowing.
Yeah, this is I swear to God, this Zoom is great. Like now there's no timer. I don't understand. Was there a timer in the room? So I'm the timer. Now I'm going to send out 1 minute left, which I would do anyway, but still I didn't see the timer. I think you got a good turnout though, you know, compared to, I mean, it's a workshop, it's long. Okay, so they've got 1 minute left.
Yeah, one group took a lot of time introducing themselves to each other, which is a virtue in and of itself. But you know, which is valid because a lot of them are from Michigan Medicine, just working in different parts of it.
Oh, that the lady, the Elham,
Mm-hmm.
I don't think she stayed for the breakouts.
No, I don't think she did.
Yeah. And then one lady from Duke had to leave early and she apologized, but she said she loved it. It's a Lindsay Kehoe. I don't know if you know her.
No.
Yeah, she's from Duke. She said she loved it and she was sorry she had to step out. So I think I'm going to close the rooms now.
Okay.
It'll take a minute for everybody to get back anyway. All right, so I'm closing them. Close in a minute. It's always a shock when you pop back in, you feel like you're in, you know, spaceship or something.
Yeah, beam me up.
Beam me up, right.
Kathy.
Right. It's just, and there's like no logic as to how it works. It's just pulls people crazy. All right, they should be closing. What's going on? 12 seconds, it says.
We're going to have a countdown.
Yeah, right. Enough counting for today.
Okay, is everybody back, Kathy?
Well, everybody's out of the breakout rooms. Yeah, there's 22 people here.
Okay,
So,
all right. So I hope you found that exercise stimulating and relevant to bring out some of the points that were made in the lecture and that came up in some of the Q&A. Why don't we go group by group and see what you all came up with. I'm not sure any of the groups finished, although I think group 3 was getting pretty close. But let's start with group 1. Who is group 1's reporter?
That's me.
Okay, you
Hi.
want to share your screen and show us what you got?
Oops, sorry. Back to the beginning.
Okay, you want to just talk us through it real quick?
Okay, so we figured out how we were going to do this. We focused on skilled nursing facilities. And then we talked about our learning community and who that should be. Residents of facilities and their families, caregivers, focus on recent fall victims. Look through facility existing QI committees to bring in some more people, administrators, physicians, PT, and then including EMS or transport agencies and receiving facility ED and or hospital staff.
Okay, let me go up to 1A for a second. If you could scroll back up. Did you, if you just had it in focus on skilled nursing facilities, sorry, but how were you going to identify the skilled nursing facilities to include?
We did not discuss that.
Do you mean geographically or?
Yeah. So you okay. So as far as you took it was you're going to use skilled nursing facilities, and you left as a future exercise which skilled nursing facilities would be included.
In our imaginary community, I guess.
Okay, good. All right.
Yeah. But yeah, it could be a huge skilled nursing facilities across a huge area. So we talked about what a fall is, and this was one definition. We had another one that I didn't capture in here. It was about intentionality behind the fall, I think. And then some measures that we looked at: fall rate per capita or fall rate per 100. Yeah. The severity as identified by a hospital admit or ED visit. And then we were looking at some payment data, fall etiology, and then we talked about all the different ways that falls could be contributed to, medical conditions per their diagnosis code, environmental factors, light, tripping, other environmental problems, the fall risk related to transfers, and then some kind of things that might contribute to this: staffing ratios, gait belts and restraints, and then training for caregivers, training for patients. And then some data elements, again, kind of on the severity. We looked at including 6-month mortality following a fall event. And then some individual things like near miss, caught and not resulting in fall, which could be difficult to capture depending on the system and how incentivized and how available staff are to, input those into a system. And then sentinel events, like the really bad falls resulting in death. Measurable preventative measures, chair alarms, gait belts, assistive devices, environmental measures, preventative training, And again, the staff ratio, screening for vision challenges and things like diabetic neuropathy, medical contributors to falls. The ones that we picked that we really liked were the staff ratio, staff resident ratio, and then our whole preventative measures category from up above, like training and environmental factors. And then the actual fall rate, we needed to include that. And that was where we left it. We didn't get to
Okay.
Great.
So, yeah, so you have a lot of good ideas there. The one thing I would comment on is that you identified a lot of what might be called variables, but you kind of mixed up the predictors and the outcomes. Like you listed fall rates as a predictive element, but isn't that what you want to kind of predict too?
We were just discussing that when our mini session left, but yeah, I think we understood that the two predictive elements above were impacting the outcome variable, which is fall rates. We were just starting to get into that.
Right.
Would have had it. We just ran out of time.
Right, and if you scroll up a little bit, go up a little higher, you did something that I really want to point out as a good thing to have been done. Right there. What is a fall? Yeah, right there. It'll be interesting to see if the other groups did that, but that is absolutely critical. If you're going to measure an outcome, you have to have an agreed definition of what is a fall that would apply across all the nursing homes. Otherwise, you're going to have what is sometimes called a data salad. So it's really very, very good that you zeroed in on the need to define a fall. Okay, all right. Let's ask the reporter from Group 2 to show us your result. Who's Group 2's reporter?
I actually can't remember what group we were.
Well,
Courtney, I am
Courtney,
thinking we're Group 2.
Okay.
This is
were you a
Anastasia.
reporter of a group, Courtney?
Yes. Yeah.
Okay, well, you report then, and then whichever group hasn't reported, when I ask for the next group, that'll be Group 3.
Sorry. All right. Can everybody see that? Perfect. Oh, there we go. Okay. So we were able to, sorry, I'm just rereading this. We specified a hypothetical health system that runs several skilled nursing facilities in Southeast Michigan. So I know that we had previously talked about the skilled nursing, just listing skilled nursing, but our thought was that in skilled nursing, it covers several disciplines. And so I think we kind of looked at that a little bit more narrow than we should have. But for our stakeholders, we included the clinical team members, family members, patients, the different specialties, so physical therapy, support staff, nursing, social workers, and physicians. We listed the administration as a separate bullet point because of the need for executive championship or buy-in to implement top-down. And then also analytics to back best practices. So for our characterizing measures, we wanted to classify a fall. So, what kind of fall was it, where it occurred, who witnessed it, attended or unattended, injuries resulting, change in medications, treatment that was provided, the pain scale, and then notifying a provider. And then also, after we filled out that incident report, who's reviewing these reports, how quickly they're reviewed, and then creating an actionable plan to mitigate the falls in the future. And then we also included an optional, which is what happens to the report. So, you know, does it get sent in is it left in a stack? Is it put into the EMR? You know, kind of how is it documented? And then how can we review it at a later date? We did all 5 data elements, time to respond to inpatient. Sorry, let me blow this up. So time to respond to patient in-room call bell. And then based off therapy assessments, patient may be identified as a fall risk with signage, shift change coverage, because we assumed that sometimes patients may take it into their own hands to move along with their day during shift change. Communication for level of assistance the patient needs for transfers, and then time of day, day of week. And this is really focusing on pain medication wearing off, and then also like sundowner syndrome, things of that nature. Our predictives are the response time of a call bell, the time of day, day of week, and then communication on level of fall risk for patients. So is there communication? Is there not? And then knowledge to performance is develop a system that communicates level of fall risk. So green is no assistance, yellow is minimal, red is heavy assistance. Identify time of day, day of week, and increase staff rounds to fit patient needs. So is this, you know, an evening hour that a patient is just becoming increasingly more of a fall risk? And if that is the case, do we need to increase rounding? And then a cutoff time for call bell response to reduce the likelihood of falls. So this is averaging how long it should absolutely take you to get to that call bell, and so that a patient doesn't attempt to move themselves.
Okay, wow, you went A to Z. Excellent. I'm curious about what do you mean by a cutoff time exactly?
So when should the call bell, you know, what is the max amount of time a call bell can go off before it becomes a fall risk, before a patient could potentially move themselves? So is that a 2-minute, you know, cutoff? Just throwing a time out there. Is that a 2-minute cutoff? What have you?
So how do you make that into an intervention? Let's assume you've established that you don't want that interval to be longer than 2 minutes. How do you make that happen?
That's a good question. If we had more time to talk about it, I may have came up with an answer for that.
Well, that's kind of something our community would deliberate. That's a non-trivial question, isn't it?
Yeah.
I mean, and hypothetically, even if you had more time to talk about it, it might have taken you quite a while to come up with something.
Yeah, absolutely.
But this is really what the community would deliberate over. They might have discovered that the time for call bell response is highly predictive of falls. Okay, that's fine. But now what are you going to do? And what are you going to do about it? Run in circles, scream and shout, or something that's likely to be more effective?
Absolutely.
Yeah. So yeah. So somebody asked earlier in the workshop, what's the harder part of this? And I think we're seeing an example here of why the intervention is the harder part of it, the intervention side. Because you have to figure out how to really make this work, and then you get into resources. You know, for example, many groups doing this said, well, we might have discovered in the DDK part that that the nursing homes with lower staff to patient ratios have lower fall rates. Well, that's fine, but what are you going to do about that if you have a fixed budget, for example? So that's where this gets hard. There was something in the chat And how measurable, yeah, Angela said, how measurable is call bell response in every facility? It should be measurable, but is it? Yeah. So in order for one of these data elements in D2K to really figure into the analysis, it has to be measurable. So that's an excellent point. Okay, let's give group 3 a chance. And group 3 is which since we don't know the numbers, group 3 is whatever group has not yet presented.
Okay, I think that's me. I'm going to share my notes from our group.
Thank you.
Conversation. Okay, hopefully everybody can see the recording sheet here. We were able to get most of the way through. My apologies to the rest of my group. I had to sort of ad lib the last bit of our conversation around the intervention, but I'll talk my way through the sheet. And when we get to the intervention, if there are any sort of corrections or additions my group members want to give, please jump in. So first, when it comes to specifying the groups of nursing homes that would be included, we talked about using a randomized crossover design to select groups of nursing homes to receive treatments, different treatments. We ended up coming up with 4 treatments, as I'll show later on. We wanted to focus on urban corporate-owned nursing homes because we believe that they would be more receptive to implementing the types of interventions that we were imagining. We did not exactly specify the geographic range of participation. And so you can see here that it's left a little bit vague with question mark. We just sort of assumed that we would be trying to recruit nursing homes nationwide. This is a group of the stakeholders that we would want to include. Let me make that just a little bit bigger. Corporate board members, excuse the typo there, executive management from the participating nursing homes, patient and patient relatives we thought would both be important to include, and representatives of the care team, including nurses, nursing assistants, nursing aides, physical therapists, nursing directors, physician leaders, and medical directors. Information technology specialists would be needed, as well as regulatory specialists. And then we thought durable medical device equipment suppliers that supplied walkers or other mobility devices to the nursing homes that were participating in the study would be good to include. We looked at a couple of different measures and additional measures in the group and tried to articulate a definition of falling that was adapted to an existing measure as best we could remember it. So a failure to maintain an appropriate lying or sitting position and then dropping to a lower level, or a situation when a patient would have lost his or her balance were it not for a staff intervention. And then we tried to identify some additional measures that we might disaggregate those falls by. So that includes the status of the patient as being either bedridden or mobile, and the severity of the fall as well. And we tried to adapt our measure for severity off of the existing measure as best we knew it as well. When it came to the measurable data elements, these are the 5 that we came up with. The number of patients who are provided with mobility assistance devices like walkers, the use of bed rails. Oh, you can ignore these X's. That's those were our votes for which we would focus on. Excuse me for that. The assistance of patients by nursing home staff, the number of elevation changes on each floor, and here we're concerned about flooring specifically, and the lighting provided within nursing home, within each nursing home. We focused in on the number of patients who were provided with mobility assistance devices, the use of bed rails.
Let me jump in with a question here.
Yep.
How would you make lighting provided within the nursing home into something measurable?
Yeah, that is a good question. There's a couple of different ways that we didn't talk through sort of measuring how well rooms are lit. But we did not really dig into how that would be measured.
Yeah, it's just interesting. I just was wondering if you had delved into that, because that's an interesting measurement problem. Are you interested in the lighting, the illumination of the whole place, or certain areas? Interesting. That got me thinking. Go ahead. I'm sorry for interrupting you.
No, not at all. We didn't talk about that directly, but buried in our conversation was the assumption, at least from my perspective, that there's certain parts of the nursing homes that are high fall areas. There are some places where the risk is greater. And that might include places that are not well lit, where there's lots of steps, for example. These are the elements, the measurable elements that we decided to focus in on for our intervention. And here are the 4 interventions that we came up with. And here's where, my team members should interrupt me if I've gone out on a limb in any way. But all residents will be provided with mobility assistance devices who are evaluated to be of need. We went back and forth on that a little bit, but we think that providing mobility assistance devices to those who are evaluated only is pretty important. Patient and caregiver education and the safe navigation of nursing home facilities will be provided to all residents and caregivers. The use of a checklist for caregivers to use with each patient as part of their daily routine in preparing beds was something that we came up with, along with verification that the checklist was followed. And then finally, this is probably cost prohibitive, but replacing hardwood flooring in high traffic areas used by patients with carpeting was something that we proposed under the assumption that carpeting would be safer when it comes to falls. And then I added a note about how these interventions would be randomized below.
So you guys decided to do an experiment. You sort of started with that idea that your intervention would be set up as an experiment instead of doing the same intervention in all the homes, and to see if things get better overall. Interesting.
The random design would help us to measure the effectiveness of the intervention.
Right. Okay. So very good. What did you find difficult or challenging about this exercise? Anastasia, go ahead.
Yeah, for me, it was lacking domain expertise. Like I have like zero experience working with nursing home data, or even being in a nursing home or working in a nursing home. So to me, not having domain experience really kind of hampered my thoughts on it.
Yeah, that's interesting. I almost picked, I used the nursing home example for this exercise because it's kind of neutral. Because what happens if you do diabetes, for example, is you get people who work with diabetics, and they come into the groups and they say, look, I'm a diabetologist, or I work with diabetics. Let me tell you what to do. So it's a challenge, but you sort of trade the challenges. On the one hand, if you choose a neutral topic, like that's not disease specific, like nursing homes, then you don't have this expertise effect quite to the same degree. But then you have a situation where almost everybody is lacking in domain knowledge, but everybody's been in a nursing home. So no, I understand. I understand what you're saying. Let's see, Mannion, you had a point.
Yeah, for our experiment design, we have intervention and control. And for control, it's a little hard. You have to do something to help them too, right? If something is good. So we decided to, for the control group, we will just delay the intervention instead of not giving them intervention.
Right. That takes you to something that resembles a step wedge design, where you randomly phase in the intervention over time, and nobody doesn't get it at all. It's kind of interesting that you get with learning health systems, you get into this interesting issue if you want to do some kind of an experiment, and this comes up because because the learning community creates a environment that is not conducive to a zero treatment control group. If everybody contributes and develops a commitment to a particular intervention, and then we say, well, we want to do an experiment, so we're going to create a group that will receive usual care, that doesn't go very well with the approach of doing this in a learning community, because everybody co-produced the solution. So, and you don't really, I was interested that group 3 did come up with an experiment, and that's fine, and it's interesting. But it does raise, whenever you do something like that, it raises these considerations. And a lot of these efforts don't do experiments for that reason. They're just trying to engender improvement and feel that if they've come up with a best solution, everybody should use it, and then we'll see how much improvement we get from everybody using it rather than partialing it out. So a lot of variation in the way this is done. Would anybody like to, I'm sorry.
I wanted to say what a challenge for me was not having time to like look at literature or standard regulatory sites and things like that, to look at definitions of falls and look at what other, standardized nursing home things are, because I didn't know anything about that. And I feel like, or look what other people have done to prevent falls. And I feel like our health system doesn't do a good job at that either. We're trying to take a lot of stakeholder involvement, which is great, but we don't go and see what other health systems have done that have worked that we could do for our own health system.
Yeah, and this, thank you. And that takes me back. If you look at the cycle, Heather, I think you're speaking to right here, right?
Yes.
Get external evidence, look at the literature, look at what other nursing homes have done. And actually, in our early expositions of this cycle, we didn't have this in there, and it was a significant omission, because just as you're saying, anybody who's doing this would want to take advantage of the fact that for any problem of interest, whether it's nursing homes or something else, someone else is likely to have done work that you could benefit from knowing about. So good point. All right, well, we're coming to the end of our time here. Does anybody have any other comments or observations you'd like to make, or any questions you'd like to ask before we call this a day? And I hope we call it what you would consider to be time well spent.
I was just going to say thank you for doing something that's not data driven, although I know that's really important, but most of y'all stuff is so much about data. I was just really excited that this was more about the process of LHS. I mean, it's still, we talked about data, but it wasn't high technical like a lot of y'all's presentations, which are very valuable, but I just was looking forward to this type of event. So thank you very much.
Well, this is really a people process. It's informed by data. But that's why I spent so much time talking about the learning community. The secret sauce here is the learning community. Everybody's doing data, but the secret sauce is the learning community. And let me make a plug, since Lisa Ferguson is here. Lisa will be doing a workshop on learning communities. If Lisa, Lisa, are you here? Do you want to say a few things about this?
Yes, I'm here. And thanks, Chuck. Yes, on June 14th, we'll be doing a workshop and we'll be talking about how to operationalize a learning community. So it'll be very practical discussion. And Chuck will be there again, kind of kicking us off. And we'll have myself and two of my colleagues talking about our experiences in starting and working with learning communities. So please feel free to register. I will put a link in the chat. So thanks.
Okay, so thank you, everybody. I think you all have my email from the slides, and if you would like
In
to,
1 minute.
pardon me? Well, I heard somebody say something. If you would like to talk further about any of this, please get in touch with me, and I would be happy to meet with you in some time in the future. So thanks for coming, everybody. Thanks to Kathy for providing the organization and the technical support. Excellent as always. And thanks again. Have a good rest of your day. Okay, bye-bye, everybody.